Tonight we are really privileged to have the wonderful Boris Lowe talking to us about carcinoid heart disease. So Boris is a cardiologist. He graduated from the University of Auckland, and after he graduated he went on to McGill University in Canada. And that's where he became one of the first cardiologists in the world to complete an advanced clinical and research fellowship in adult congenital heart disease. Since then, he's worked at the prestigious Cleveland Clinic in the USA, where he was the chief fellow in advanced cardiovascular imaging. And while he was there, he achieved the highest possible level of certification in the areas of echocardiography, CT, and MRI. He is now brought all of those skills and experience back to New Zealand. He works in Auckland at the Green Lane Cardiovascular Service, and he also consults part-time at the Heart Group. So we are incredibly lucky to have someone of Boris's calibre in New Zealand, and more than that, he has dedicated he's dedicated to neuroendocrine cancer and carcinoid heart disease. So we have someone in New Zealand who's seen more cases, has more experience of this disease than anyone else. So we're both really lucky to have him as part of the network that supports our community, and also that he's happy to give his time to us tonight to provide us some insights and knowledge and also answer questions. So thank you very much, Boris.
All right, yes, so look, I'm very pleased to accept this invitation, because when I look back at the decade that I've been caring for, carcinoid heart disease patients, I'm really quite proud because no one taught me to manage this condition, but also I'm delighted because year after year, the program continues to grow. This evening, we've got a number of objectives, and it's as much about your questions as some of the things I thought you might want to know as a patient. I wanted to try to understand how the heart is involved with carcinoid heart disease. Why is it important? How do we diagnose it? And how do we treat it? And we should have plenty of time at the end for questions. I don't actually mind people interrupting as we go, but I imagine if there is a large number of attendees, it might be better we just leave that to the very end. But hopefully I'll just go through very, very slowly. We've got plenty of time. I thought before we get underway, I thought I would try to at least describe what do heart valves do. And it's important because you've already got a diagnosis of cancer. The last thing you want to hear is that your heart is involved. I think many of my patients tell me that when they get told that the heart is involved, it's like this is the last thing that's going to happen before the end, and it's not. And heart valves are really quite ingenious. I've got a very complicated slide here, and the heart has been dissected in half, and you can see that there's 4 chambers. Blood comes into the right-hand side of the heart as deoxygenated blue blood. Then from the right-hand side, it gets pumped to the lungs to get new oxygen before it returns to the left-hand side. And once it's got its new oxygen, then it comes out to the body through the aorta. Now, carcinoid heart disease really only involves the right-hand side of the heart that you see here. So you have a top chamber called the right atrium, and it goes through a valve, and a valve then passes its blood across to the right ventricle here, and this is connected to the lung tube. Now, hidden amongst the muscles within the right ventricle, you've got the tricuspid valve, and this is one of 2 heart valves that you can see. The other one's the pulmonary valve, the lung valve, which is not actually seen in this illustration. But the tricuspid valve, I often liken it to a parachute, and it's why I've got this picture on the right from NASA. And it really shows 3 parachutes, just like the 3 cusps of a tricuspid valve. Fully deployed, they are open, and they oppose each other, so they have a seal when they all meet. When the heart contracts to pass its blood towards the lungs, then a muscle pulls on these strings, and when it pulls them apart, it allows blood to then to enter back into the heart to be circulated again. So it's quite fitting that I've got 3 parachutes here, because this is the reason why it's got a tricuspid valve. You've got 3 cusps. The names of them aren't that important, but I think describing a bit more about their function is important. So in this simple illustration, I've got blood returning from the body to the right atrium that you see. Then you see the tricuspid valve opening, and it has a parachute at the top, and then cords which are like strings of the parachute that pull on it to open it. The purpose of the valves is to regulate the direction of blood flow so that when the heart squeezes blood, it goes in one direction and not backwards and forwards. So then how is the heart involved in carcinoid heart disease? Well, what you get is you get these thick plaque-like deposits on the valves, and can be on either surface. The valves are by far the most commonly involved, but the strings or the chordae are also involved. The right ventricle or the right atrium can also be involved, as is the draining tubes that drain blood back to the body called the vena cava. Infrequently, the lung tube, the pulmonary artery, is also involved. Here is a histology section where the valve leaflet you see in pink, but the darker pink is the fibrous thickening of the valves, and you can quite clearly see why a thin, pliable leaflet now becoming very stiff, thickened, becomes retracted and immobile. And then those leaflets that you saw in the previous slide, they either fail to open, in which that causes narrowing or stenosis, or if they fail to close fully, we call that regurgitation or incompetence. So do look away if you've not had dinner, but this is a section of pathology of a pulmonary valve. And normally the leaflets, you can almost see through them, but it's so thickened it's become opaque that you can't see. Likewise, the strings are normally very fine, but they've become very, very thickened because of the carcinoid plaques. And what should be very thin leaflets for the lung valve has been so thickened that it's remained open. Now, this is a very, very busy slide. I'm going to just talk through it very, very slowly, but it's quite important because it allows us to understand why is it that we have to measure some things, and why is it that some organs are involved, and why the left heart is not involved. So most of the tumors involve the gut, and what happens is that the neuroendocrine tumor uses tryptophan, which is an amino acid, and it uses tryptophan to secrete hormone. One of those hormones is serotonin, which is called 5-HT, hydroxytryptamine. Let's just not call it that anymore, let's just call it serotonin. After it's released into the bloodstream, it makes its way to the liver, and 2 things can happen. Usually, serotonin can be deactivated by a number of enzymes. One of the byproducts is called 5-hydroxyindole acetic acid, a real tongue twister. But it's this product that you will often have measured in the urine as a measure of the disease activity. When the liver is involved with the tumor, then it itself makes serotonin and therefore bypasses this pathway to deactivate it. Serotonin therefore gets released directly back into the right-hand side of the heart, into the right atrium, into the tricuspid valve, right ventricle, and through the lung valve that you can also see in this picture. Now the left heart tends to be spared because you've got a dividing wall so that it can't cross to the other side, or when it does go through the lung also has the capacity to deactivate serotonin, much in the way that liver is. And so those 2 pathways serve to protect the left-hand side of the heart, but they also mean that when you have liver involvement from your neuroendocrine tumor, you are therefore at risk for developing carcinoid heart disease. So a very busy slide, but hopefully you can appreciate that normally you have a normal way to deactivate it, Some foods, for example, are high in serotonin. And so when you prepare for a test to measure the hydroxyindoleacetic acid, like banana, avocado, kiwi fruit, they all need to be withheld for a whole day before the measurement of this byproduct. Okay, so now you can understand why it's just the tricuspid and the pulmonary right-sided heart valves involved. And it's usually when the liver is involved that you're at risk for developing heart disease. Serotonin is one of many things that are secreted by the tumor that initiates the plaque-like fibrotic process that you see. Very, very rarely, much less than 10%, I think I've only seen it in one patient where the metastases actually involve the heart muscle in itself. And it's one of the joys of doing cardiology is that I don't have to deal with the burden of cancer. And fortunately, even for someone who has neuroendocrine tumor, it's actually it's quite treatable and has options. So how common is it? Well, maybe about a third of patients who have neuroendocrine tumors have what's called Carcinoid Syndrome. This syndrome is given to the effects of serotonin and a number of other neuroactive peptides that cause flushing, diarrhea, breathlessness, or low blood pressure. And then eventually, as many as half of the patients who do have this syndrome will then develop carcinoid heart disease. So although the tumor itself is rare, the involvement of the heart is not as uncommon as you might think. And that's one of the reasons why we've become a national network, and you'll see why soon. So why is the valve disease important? Well, it's important because it determines a lot of outcome. Mostly, as you know, the neuroendocrine tumors are very, very slow growing. But once the heart is involved, it can cause the heart muscle to be weakened if it's having to cope with more blood. So you've got the normal amount of blood returning to the heart. And then from the previous heart cycle, you've got the leaking blood that's gone backwards. Or if a heart valve like the lung valve can't fully open, then it's got pressure, it has to generate a lot more force to get that blood from the right-hand side to the lungs. If we look after diagnosis about 3 years, then about a third of patients are unfortunately not with us anymore. Compared to those who don't have heart involvement, your survival is a lot less, on average about 1.6 years compared to 4.6 years if you didn't have your heart involved with neuroendocrine tumors. So how do we detect heart disease? Well, it's not as straightforward as it is for many other diseases, partly because early disease, there isn't much in the way of symptoms. When the heart muscle becomes weakened and can't supply what you demand of it to work and do your daily activities, then we call that heart failure. And those symptoms can involve swelling of the feet, swelling of the abdomen or the tummy, feeling full, partly because your liver is engorged, partly because of the fluid buildup, but you also have breathlessness and fatigue. Unlike other heart murmurs, the murmur or the turbulent blood flow heard through a stethoscope is often very quiet, and that's because the lung circulation is a low pressure circuit as opposed to the left-hand side of the heart, which pumps the body with much, much higher pressure. So therefore the noises of turbulent flow are a lot more audible. So you can't simply rely on just seeing a doctor sometimes, because many of the symptoms that you've got don't necessarily mean that you do or don't have heart disease. An ultrasound of the heart or echocardiogram is really required for diagnosis, but also for monitoring and surveillance for follow-up of all patients who have carcinoid disease. And depending on your symptoms and your disease, that might be yearly, even if you are otherwise well, or it might be even half yearly. So the symptoms of valve disease, if it starts early, you might notice shortness of breath and feeling fatigued. But if you look at patients who have neuroendocrine tumors, they can also feel short of breath, That is the effect of serotonin. Lack of energy, that's because the tumor is using half of what you eat. Much later in more advanced disease, your lower legs, not really your hands or your arms, can swell, and similarly with your tummy. If you present it to your doctor with shortness of breath, a feeling like you're lacking in energy, swelling legs, and you've got a swollen tummy, your doctor might order a pregnancy test. But actually, they are all symptoms of right-sided heart failure. And so we've got a number of things that we've already seen. But enlarged liver and the spleen can be involved by the disease process itself. Full neck veins is called distended jugular veins. This is the reason why your doctor keeps looking at your neck, because that neck vein drains into your heart. So there's a lot of back pressure from too much fluid. It becomes engorged, and it's quite a crude way to assess how much extra blood volume is going into your heart. Here are some pictures, some still frames of a heart ultrasound of a tricuspid valve. So this is the first valve that the serotonin might be exposed to when it enters the right-hand side of the heart. These look very foreign to you, but blood enters this chamber. This is the right atrium. These little fine things you see here, actually the tricuspid valve, and in this chamber to the top left-hand corner is the right ventricle. Tricuspid valve, right atrium. In this picture, you see this is a much more normal looking valve in the middle, but see how the ends of it are bright white and thickened? And this is the other side of the valve, it's even more thickened. It's become so thickened that it also involves the strings, which you see here that we talked about before. It's just another orientation where they might be stuck in the open position or retracted because of the scar or the fibrotic process that you saw happening. If you see that in a movie, this is what a real-time heart ultrasound actually looks like. You've got blood entering this chamber, you've got the two valves, and they normally should meet each other, but you can clearly see there's a gap. There's a gap because this is now stuck down. The strings are too short so that the two doors don't actually close to meet. And because they don't meet, then when the heart does squeeze its blood, most of it still goes forward, but proportion then goes backwards. And that's what you see with all this color here. This is a very large degree of leak, and this is called tricuspid regurgitation. The other valve that's involved is the lung valve. Here is another ultrasound. RV outflow tract is the right heart leading onto the main lung tube. And again, you've got, in this occasion, two doors. You've got two doors that are also thickened and also stuck in the open position. So when you look with color, you see that there's turbulent blood flow going forward, but also turbulent blood flow going backwards. So this one's got mixed disease, both of narrowing and leak. The culmination of both the valves being involved is that there's extra blood entering the right-hand side of the heart. Normally, the right-hand side of the heart is about, in this view in particular, is about a third of the size of the left heart, but it's a lot bigger than the left-hand side. And so here you see the tricuspid valve, a very enlarged right heart, but still managing to squeeze. Other tests that could be used include a blood test, and this blood test is quite confusing because it's actually called brain natriuretic peptide, is what the B stands for. But it actually doesn't really have much to do with the brain because it's actually released by the heart, and it's released by the heart when it's under stress or under strain from too much volume or too much pressure. And it's been shown that actually the severity of rise in the NT-proBNP correlates with your heart involvement. If you set off a threshold where your NT-proBNP is above 31 picomoles per litre, which is the units we use here in Auckland, then it can actually detect the majority of cases. And you might use this where you don't have heart ultrasound near to you. You may have a blood testing centre, and they can send it off to a number of specialised laboratories who can measure the NT-proBNP brain natriuretic peptide. I tend to use this because it correlates better than that byproduct that we saw before, the 5-HIAA. Crudely, more 5-HIAA also tracks with the risk of your heart involvement, but it doesn't, its correlation is weaker when compared to this particular type of blood test. And the similar stories for chromogranin. There are other things that influence the level of its rise. We can't really use chromogranin to say whether you are at risk or not. Now, about a decade ago, I started using cardiac MRI to also assess my patients with heart disease from carcinoid. And I found it quite interesting because when I had a conversation with Peter McCullum Centre in Melbourne, I told them this is what I do, and they said, oh gee, that's new. We've never had MRI as part of our program. Can you tell us how to use it? And I'm glad to say that I usually find it supplementary to a heart ultrasound scan, but there's a lot of advantages to MRI, and whilst I appreciate many of your smaller centres don't have MRI or the expertise, it is a service that I provide nationally and happy to assist wherever you might be. Likewise, you see the 4 chambers of the heart. You see the swollen right atrium that's become enlarged. You see the thickened valves as you did with ultrasound scan, and you see the enlarged right heart. On the right-hand side, I've got a different view, but now the valves are white color. The white color appears after I've given something called contrast that contains gadolinium. And gadolinium gets into water, and the excessive water in the valves from the scar tissue now shows up as white. So I can use this not only to see where carcinoid involves with the plaques, it can involve also the heart lining, but I can also see function as well. And one of the biggest advantages of using MRI is its ability to measure the size of the right heart. The left-hand side of the heart is quite easy because it's almost a shape like a half a bullet. And so it's quite symmetrical. But the right heart, if I had to describe it to you, I'd say it was like an upside down horseshoe where blood comes in one side, goes through a long tube that's all convoluted and folded up and enters the other side to the lung. But MRI can actually slice it just like a bread, and then we can quantify these by tracing each of those slices into a volume, and then multiplied by the length, we can get a volume. Similarly, we can measure flow across a chamber or across a blood vessel. And in this case, we've looked at the amount of blood flow coming out of the heart into the lung artery or the pulmonary artery. Blood flow going forward as the heart pumps is normal, but going backwards is not normal. And this backwards is the leak that we have previously seen in different modalities using heart ultrasound scan. These are the sort of pictures that we might see with MRI, and although there's lots and lots of them, there's many more that we do take. But here you've got a whole stack of the heart in what I call a short axis, where you're looking down the barrel of the heart, and you see the left heart as a round circular, but almost a funny shaped kidney bean of the right heart. But it's a lot easier to see the size of the heart, its performance in MRI. Here's an example of one of my patients who had actual neuroendocrine tumor metastasizing to the heart. You see these faint grey thickening of the heart muscle, and then having given gadolinium, they too show the bright whitening. So very much easy to see, and this is one distinct advantage where you can characterize the tissue with MRI, but you can't characterize tissue by MRI. Doing an ECG, or electrical tracing of your heart, unfortunately is not sensitive enough to detect any problems with carcinoid heart valve disease. It can be non-specific, or actually, like in this case, it can be normal. Similarly, an X-ray looks relatively normal. You can't see cancer in this. And so, although they are part of the workup, we shouldn't stop there to say that you don't have disease. So what treatments are there? You've got treatments for your tumour. There's no definite evidence or yet to be determined treatment, even from peptide receptor radionuclide therapy, that if you have that early, does that either regress or stave off the onset of carcinoid heart disease? We just don't have that data yet. For management, there's medical management with diuretics, which is like a water tablet that makes you pass a lot more water, because of the right-hand side of your heart, it can't pump blood forward, backlogging fluid, then you accumulate it in your legs, accumulate it in your tummy. But by taking an extra tablet, you'll pass more water to relieve both the swelling in your feet and also in your belly. There's octreotide to inhibit things like serotonin. They probably make only a small difference to the progression of heart disease. There's non-cardiac intervention. You can try to resect the tumour, but it's not always practical to do so. And of course, there's a bleeding risk involved with that too. The liver is a very vascular organ, and if it's got back pressure from a leaking valve, then a surgeon wouldn't really want to go near it because the smallest cut could cause excessive bleeding. So really the only effective treatment for carcinoid heart disease is to have surgery, really just replace the valve. Timing of valve replacement is very individualized. It's determined by a whole constellation of how you feel, the severity of your symptoms, what's happening to your right heart. I really would like to catch you early. If the right heart is so advanced in its involvement that it's so weak, the chances of a successful operation are much, much more diminished. And many times the demands on your heart pump function are much, much higher after surgery than before. So starting off on the back foot before surgery is not good. Most neuroendocrine tumour has quite a good outlook, being slow growing, but if you've got an aggressive tumour, it doesn't really make much sense for you to have a major heart surgery if your survival is not determined to be good. Peter McCullum have had only one death in their entire existence for patients who underwent peptide receptor radionuclide therapy. The patient who passed away had untreated heart valve disease, and so they've taken the philosophy that if you have heart disease involvement, you should always get that fixed first before you have peptide receptor radionuclide therapy. The reasons for that is because during a PRRT, you give amino acids and you give fluid. And so if you're already fluid overloaded, giving about a litre of fluid can send you into heart failure, where your heart on the right-hand side just can't cope with the excessive volume. Perhaps less well appreciated also is that PRRT can often release a whole lot of the serotonin hormones as the tumour is attacked. The serotonin that's released can also mean that the right-hand side of the heart, already working very hard to pump blood forward, now has low blood pressure where you can't fill it. And if you can't fill a weakened heart, then you can't get blood forward to fill to the left-hand side. And therefore your brain not getting blood flow could make you feel dizzy. Your kidneys, which are a very vital organ, has then very, very low blood pressure, and so you have kidney failure. As we stated before, having any liver surgery is important just because the back pressure and the bleeding risk if the heart is not fixed. Main choices of valves really come down to tissue valves or mechanical valves. And it's probably something where I've deviated from Melbourne in that the majority of their cases, they do a tissue valve. In some cases, I've elected to pursue a mechanical valve. A mechanical valve has the advantages that it's very, very durable. It has the downside, though, of needing to take anti-blood clot medication to stop clots on the valve. But it isn't always easy if you're going to have subsequent liver or gut surgery. Then trying to manage your blood clotting around the time of surgery could put you at risk for bleeding at the time of surgery, but stopping it beforehand then puts your heart valve at risk for blood clots. So there's both pros and cons. Similarly, with a tissue valve, it's got limited durability. For the left-hand side of the heart, without carcinoid disease, I think modern tissue valves can last well in excess of 10 years. The right-hand side of the heart, if you didn't have carcinoid disease, would be expected to last a lot longer because being a low pressure, lower stress on that valve, I'd like to think that the durability is a lot longer. The advantage really is that you don't need medication to stop blood clots on it. You might for a short time, early after surgery, but then as the lining grows around that heart valve and coats it, then the risk for blood clots is virtually like your own heart now. One of the reasons why I've, in some patients, chosen a mechanical valve is because if you replace the tricuspid or pulmonic valve with a tissue valve, and you continue to secrete serotonin from your liver metastasis, then actually the replaced valve can also become very thickened, as happened in this case. And what initially was a good outcome after surgery, just over a year later, becomes very, very leaky once again. You're back to square one. Don't be fooled to think that if you get a tissue valve, this is always going to occur. I would say from our experience here in New Zealand that of the patients that I know, I'd say the risk for carcinoid involving the heart, again with a replaced surgical tissue valve, probably orders in the order of about 5%, that low. In a couple of my patients who have unfortunately had the bioprosthetic valve become non-functioning, then there is rescue therapy now. This is probably something that we didn't have 20 years ago, but you have keyhole surgery or transcatheter valve, where we can actually replace a valve through either a leg or an armpit blood vessel without cutting open your chest to deliver a valve that's crimped onto a balloon into that incompetent valve that's replaced here, and then expand it so that it sits. This, of course, is the left-hand side of the valve that's shown here, but nonetheless, that technology is available for the right-hand side as well, and we've done a couple. So that can be like a bailout therapy. If in 5 years you had a tissue valve and still had significant leak, you got another option to rescue you. Now, valve surgery seems like a big deal, and it does, but if you get through it, it's definitely been shown to improve your symptoms. So living with better energy, living without breathlessness when you walk to your letterbox, being able to run around with your grandchildren are all good things you could look forward to. And for selected patients, it should make you live longer too, provided that your tumor is not aggressive. Now, my message to you is that the symptoms of carcinoid heart disease overlap with that of your tumor, even without involvement of the heart. Things like bloating, fatigue, and breathlessness. And so if you have those symptoms, you can't say that you don't have heart disease involvement. But if it progresses quickly, that is an alarm bell. I'm sending this message because one of the things I really don't want to see is patients who refer to us very, very late, where the heart valve can be reduced to just nubbins. There's no valve at all. It's all disintegrated by plaques. That there's actually no doorways inside your heart. And then your right heart becomes very, very enlarged and weakened. And therefore, the options for surgery are really non-existent because you wouldn't survive it. Screening, both with blood tests and ultrasound, is important. MRI in selected few. Ultrasound, even through the food pipe or transesophageal echocardiogram, can also be used to get more detail about your heart being involved. Valve replacement is the only effective surgery. Its timing and the valve choice is individualized. And so my message to you is really ask your doctor to check your heart for valve disease if you have increasing breathlessness, or you have shortness of breath that's worse, swollen feet, or a bloated tummy. In many cases, you have paid your taxes, is what I would say. Being checked out, being told that your heart is fine, is still very, very good use of your taxpayer money. Does anyone else have any questions they want to ask about a carcinoid heart disease?
Boris, it's Michelle here. I'm just going to pop in. There's one from Ken Falconer in the chat. Just wanting clarification that the right side of the heart is the same side in the body as the right arm. So just clarifying that it's not, the way from looking at it versus being inside the body and looking out.
Yeah, both are correct. So the right-hand side of the heart refers to the side that receives blue blood. That is facing towards the right arm. You're correct, even though the heart sits pretty much in the center, it points a bit to the left, but yes, it's the right-hand side. And so you can, so it's not like that, it's only the right arm that swells or the right neck vein that becomes engorged. When we refer to the right-hand side of the heart, it is partly because it's facing the right-hand side, but we often refer to that functionally as the right heart, as the one that receives blue blood, and left heart, the one that pumps red oxygenated blood around the body.
Reflecting on your talk and the pressure on the health system and the fact that we don't want people to wait, is that where you'd like to see a bit more use of the Bnp screening?
Yeah, I think the data there now is really quite robust, and so it's not to replace the heart ultrasound scan, but can be a used way to help triage that if it is high, maybe you should get an earlier priority ultrasound scan. But if you've got stable symptoms and the NT-proBNP is low, maybe waiting 6 months may be okay. But if in 6 months symptoms change, that can be reprioritized. But yes, that is quite true. I would usually ask a NT-proBNP to be done almost in any patient who's got liver involvement or more rarely lung involvement, to have a baseline performed, because it's just so useful to know not just the level, but the magnitude of change, say in 6 months or in 12 months, when it's not clear where your bloated tummy might be a little bit fuller or not. It's quite hard to gauge, but having a objective test like a biomarker as a blood test is very, very useful, not only to yourself, but to your doctor.
I'm going to ask the idiot question here, Boris, and just ask, is that something that is routinely done, or is that something we'd like to see done more routinely?
I would encourage it to be done routinely, and someone who's either got early involvement to be done as part of surveillance, but also for screening, where because the symptoms and the clinical examination at the bedside can't be relied upon to say whether you have heart disease or not, I would like to see the NT-proBNP used a lot more widely, almost to the point that when patients are referred to us, that I'm concerned about this patient because the NT-proBNP is this, with the heart ultrasound scanning like that, with progressive symptoms over the last X number of months. And that blood test is, although it's specialised, it's available at every district health board. Although they may not process it in Rotorua, they would send it off to Waikato. In Northland, they'll do it. And over the years, it's got cheaper to do. It's been told to me that it costs $50 a pop, but $50 is very, very well spent when you consider an MRI scan costs $2,500.
Absolutely.
At what stage would you recommend the MRI to be done?
I tend to do it when I'm considering someone for surgery. I would tend to do it in everybody who's planning for heart valve surgery, so I can have a lot more confidence in recommending when it's being done. and the likelihood of you coming out the other end. I wouldn't usually advise that your MRI scan be done, say, as part of screening. I think it's inappropriate use for MRI. Likewise, I don't always advocate for someone to have an MRI at your local hospital is one thing, but I think having the expertise and the software to analyze it is perhaps equally important as interpreting the data. And I think with our background in congenital heart disease, at Auckland, we're quite well positioned to look at and assess and recommend treatments for the right side of the valve disease for that very reason. So likewise, if your MRI scan can't be done, that's also part of the national network. So access to specialty surgery, to specialty cardiology, specialty MRI, or even transesophageal heart ultrasound scan is all something that can be offered you through Auckland. And I think a number of the DHBs who've referred a number of patients know that they can just stop at a transthoracic ultrasound scan, discuss with me, refer patients up. The only inconvenience to you is sometimes traveling, where when you come up for maybe a few days, I do 3 or 4 tests on you as well as a consultation. So it can be quite time pressured, and it can be quite exhausting to then travel and then have lots and lots and lots of tests. But your geography and where you are based should not determine your access to tests. That includes an MRI. I guess that's a very timely way for me to go on to my last slide, and although we can still have questions, I think one thing I would like to say is a big thank you to the people who have supported me and you. And I think look at the people who've been really influential to the Neuroendocrine Cancer, or previously Unicorn. I can really thank Avril for her commitment to patients. I see it every day, but to the level that Avril takes it, it's something to be admired. Ben for his vision and expertise, Malcolm Leggett for his inspiration and determination, and really for David for his surgical skills and being so open to say, look, hey, some of our patients have got very challenging circumstances. Can we still offer them something? And the support that you have for each other is really something that's been enabled by the Neuroendocrine Cancer New Zealand. And so, Sonia, when you come back here, you shouldn't feel like it's you and your doctor having to fight everybody else. I think with the support of a national program, it's really utilized our advantage to be a small country where the hub and spoke approach really can be effective. And although I also trained in Canada, that exists in many spokes and hubs around large centers. But you have each other, you have the Neuroendocrine network, and we can help to fight for you.
I'd just like to echo that, Boris. Avril is an astounding human being who really does care about each and every person in our community and goes the extra mile, as does Ben and as does Malcolm, and I don't know David, but you know, as you say, everybody is really essential to this you know, tight-knit little network that provides this quality of care for everyone, regardless of where they're living. There's a couple of quick little questions in the chat that I just want to pop in front of you, and then there's a Andy's got one that might take a little longer to answer. But Karen's asking, just following on from the BNP biomarker discussion, that given is that blood test an easy ask, especially if you're faced with waiting for a period for an echocardiogram? Is that something you would suggest that patients could chat to their specialist about?
Yes, it would be. And it's a standard blood test to look for heart failure. It's often advocated, say, even for your GP who won't have direct access to heart ultrasound scans. So many of the referrals we get into our hospital for heart failure as a whole the NT-proBNP is a test for heart failure, not for carcinoid valve disease. So it is well known in the primary care. It should be a test that your cardiology is familiar with. Believe it or not, I'm probably the least likely to request it, not for carcinoid disease, but just because I've got so many other tools available to me, I tend to often skip that step because I've got other tools at my discretion. But that's a luxury, unfortunately, or fortunately, of being in a quaternary centre. But no, it's not a specialised blood test where you mention it to your doctor and they think you're speaking Russian. No, it's a common test. I would be surprised if it was still $50 now, but it should be something you could easily ask for no matter where you are.
Thanks, Boris. I think that might be a solution. Anita's posted. So Anita, not sure if you mind, honey, if I say where you're based, but you are someone who doesn't have access to the bigger centres for healthcare, and she's saying the last couple of months she's developed all the symptoms you've talked about tonight, Boris, but her doctor, not sure if it's your specialist or GP, is not really sort of wanting to do much more for her at this point. So yeah, so Anita's on the west coast of the South Island, so not a centre that's known for being you know, it's not a big medical centre. So Anita is in a situation where her doctor's reluctant to press go on any further tests for anything, and she's asking us anything she could do. And it seems to me, and I'll put it to you, whether that, you know, just that blood test is a good place to start, to, you know, have some results that would open up a conversation, or perhaps you've got suggestions for what you would want to see done for someone who's got all those symptoms developing quite quickly.
And it's hard for us to comment on individual circumstances without knowing the specifics. But unfortunately, there are still physicians out there who think that your cancer is determining your prognosis, and that thinking about heart surgery is the last thing. So if that's not in the agenda to keep you living better, then many doctors unfortunately still are of the view that, okay, let's just let the cancer, let it be. They don't operate on patients with cancer. That is changing, and is one of the things I'd really like to spread through the talk today, that as a patient, you can spread the word that actually those attitudes are very old. If we catch you early, then for individualized selected patients, you are eligible for surgery. So I think that's probably one important thing your doctor needs to understand. And often, once they understand that there are treatments available, not only is it available in New Zealand, it's available with consultation with your specialist that you usually see. So even though in the West Coast you might be seen at another centre, it's a network, it's a link, and they don't have to feel that they're going to be taking on complicated tricuspid valve surgery by themselves. I think understanding that attitude is important, and maybe discussing that with your doctor to say that, hey, I've recently been to a talk, I hear there are treatments available, and although cancer seems daunting enough, could I get this test in the absence of having a heart ultrasound scan to see whether my heart might be at risk? Or perhaps ask it that way. A blood test is quite easy for a doctor. It's merely ticking a form, and then if it's high, then that not only gives them, I guess, appetite to see what this is all about, but it can also be used to spark a conversation with another bigger centre, if not to myself. So yes, I think asking for that blood test is a good start. Not a replacement, but certainly a good initiator for discussion and progression.
Thanks, Boris, for that really beautifully worded answer. And there's a message in here from Karen saying specifically to thank you for your messaging and your support of patients. helping them to advocate better for themselves. And I think she said that beautifully. One last thing I'm going to throw to you, and I'm really conscious of your very precious time, and it is already 6:30, but Andy's asked about your thoughts on doing New Zealand-based research in carcinoid heart disease and patient outcomes, as there seems to be very little research on carcinoid heart disease out there. So that's a really open-ended question, so I'll leave it to you how expanded or contracted you want to make your answer to that, because I am conscious of your time, but it's something that we're really interested in and how we can support at Neuroendocrine Cancer New Zealand as well.
Yeah, we are too, and it's one of the beauty of the network in a small country, and each of us having a national health index number is that we can track outcomes, and Andy is not wasted. We certainly are active in collecting information. About 4 years ago, we stopped and looked at surgical outcomes, for example, but because the numbers were too small, I didn't want to publish a piece of work that would be overshadowed by much larger centres. Although we're a national network, we have deviated from some, and it'd be really nice to compare what our outcomes is to others. And so, yes, that very much is something I'm doing in partnership with David, our surgeon, with Ben, and yes, the benefits of research cannot be understated, but you're absolutely right. We haven't lost that vision.
So look, I think it's a lovely place to finish, and I would love to just reiterate Karen's point about how your concern for everybody getting the best care and everybody getting access to the network has been fantastic. And I think it's really, heart disease, cancer's scary enough. Heart disease on top of it is terrifying. And your, really hopeful approach and just giving people the knowledge to know that they can, that there is a way through this, but not sitting and waiting and, being their own best agent and saying, hey, my symptoms have changed. Can we take a look at this? I think it's really, really positive for our community. So thank you so much for your time, Boris. We are incredibly grateful to you. It's been such a treat to have you talking to us and sharing your wisdom tonight.
And thanks very much for the invitation. And of course, I'm happy to work with anyone, be it patient or physician around the country. And my message really is don't feel alone. Cancer is daunting enough. Heart surgery is daunting enough. Surgery for either is daunting enough. Yet to throw all three together in an individual patient, I can only imagine what's sitting on your shoulders. You have each other. You have your local hospital, but you have the Neuroendocrine Cancer Network, and you have me here as well. So if you ever feel like the fight is too much or it's really uphill, do reach out, and I would be very glad to help you.
Thank you so much, Boris. I will let you go and head home and get some dinner, and just know how grateful we all are to you for what you've given to us tonight, and also for the passion and care that you lavish on our community and our patients. It's great to have someone of your skill. Thank you.